able to address you with some of the things that is highly on my mind in my working role and which I like to present for you and discuss with you as well. This presentation is called The Future of Prosthetic and Orthotics.
I thank Dr. Anton. Dr. Anton.
Thank you.
Yes, I have to introduce you for participation, please. Okay.
Go ahead.
We are honored to welcome Dr. Anton Johanssen. Before I begin, I hope I said your last name right. Dr. Johanssen, please forgive me if I didn't. Yes, Johanssen?
Well,
Yes.
Johannesson, very good.
Johannesson, yes. Dr. Anton Johannesson is a European certified orthotist who graduated from the University of Jönköping, Sweden in 1990. He earned his PhD in orthopedics from Lund University in 2009 with thesis on lower limb amputation in patients with vascular diseases, which has significantly contributed to advancing knowledge on post-operative care and the prosthetics outcomes. Dr. Johanssen was the founder and CEO of Orthopedic Technology in Kristianstad, and later served as a clinical manager of prosthetics at Lund, or at Team Olmed clinics in Sweden from 2014 to 2023, where he focused on clinic innovation, education, research, in cooperation with USAR R&D since June 2023. He has been Director of Clinical Development Prosthetics at USAR EMEA, that's Europe, Middle East, and Africa. Internationally, he has worked with non-governmental organizations in Namibia, South Africa, Haiti, and Zambia, and is currently supporting the rebuilding of prosthetics and orthotics education in Ukraine. He has served as a convener of ISO TC 168 working groups 1 and 2, and has twice been awarded the award or Hard Kitchen Prize by the American Academy of Orthotists and Orthotists from 2018 and 2020. All right, I will let Dr. Anton Johanssen take it from here. You can start.
Thank you, Ayman. Yes, you told the most of me, and thank you for that. I have had the honor to work in more than 30 countries and work inside at least 70 clinics, not only visit them, but also worked inside of them, which has given me a lot of insight in how things are in the different countries. So let's go to the future of prosthetic and orthotics. This presentation is divided into 4 parts. I will talk about education, technology, availability, and I will end my presentation with a few words related to ISPO. If we look at the current situation in the world, we have over 2.5 billion people worldwide need one or more assistive product, such as mobility aids, hearing aids, vision aids, prosthetic, orthotics, communication devices, and more. The WHO estimate that there are 40 million amputees throughout the developing world, but only about 5% of them have access to any form of prosthetic device or assistance. In a war-torn countries, such as Cambodia, Iran, and Afghanistan, 80 to 85% of amputees are landmine survivors. Angola alone has an estimated 10 million landmines and the amputee population of 70,000, of whom 8,000 are children. In Syria, during January this year, more than 60 people were killed and 90 injured by landmine, many while tending to the land or grazing animals. Not to mention the situation in Gaza or Ukraine. I have been working in Ukraine for the last 3 years, and there's an immense number of amputees there. They are young, they are active, they have many years left to be served. And as I mentioned, only 1 in 10 people in low and middle income countries have access to the assisted products they need. There is immense shortage of trained staff in most countries today. The solution to the challenge created by the lack of P&O manpower and the time-consuming technique currently used in manufacturing is to either train more technicians or optimize the process of manufacturing a prosthesis or orthosis. I think we have to do both of them. We need to educate more people, but we need also to use technology that is faster in production. If we look at the education and what has changed throughout the year, in this article that was published more than 60 years ago, it was written in an American magazine, Orthotics and Prosthetics. And the name of the article was The Future of Education in Prosthetic Orthotics. The requirement for a prosthetist orthotist at that time was similar today. They describe it, one we will call the prosthetist orthotist, and the other profession orthopedic technician. The prosthetist orthotist should possess the following characters. That was the interesting part. He should be professionally trained. That's good. He should emphasize in his professional work on planning and fitting and diagnose of prosthetic orthotic problem and handling patient. He should be qualified to work with physician, therapist, and other professional people in a clinical environment. And I think we will agree on this, that these things are as it is today. But the fourth one was interesting, and I'm not quite sure that you would put it in the description of education today. They wrote, he should be bright, intelligent, clean cut as me, able to think, solve problem, and apply basic principle in his work. But notice, they say he. There was no discussion of a female prosthetist at that time. Now every second prosthetist, orthotist who goes through the education in Europe and US are female. The technician did only need a 2 years college program, and he should focus on the clinical work, fabrication procedure. He should be qualified to work primarily with prosthetist orthotist. But he should be bright. It didn't have to be intelligent, clean cut, or able to think. He should adapt at mechanical work, able to solve production problem, and in some instance be a candidate.
Anthony, you are muted, so just if you can unmute yourself. Okay.
Okay, you hear me now? You hear me now?
Yeah, we can hear you.
Can hear you.
Okay, thank you. We go to the difference today is that we have in many places more structure in our work, but the profession is the same. We have prosthetists, orthotists, and we have technicians. And these are the people that try to help the patient. And as I said, around half of them in Europe are female prosthetists, orthotists today. We must align future education with emerging technology. Part of the answer to optimize manufacturing workflows and strengthening the evidence base for what we do. It's not only producing, we have to show the benefit of it as well. The question is whether education can keep pace, or will it keep teaching legacy or old method instead of new techniques? Education program may need to lead the changes, especially when health systems are reluctant to fund innovation and many patients can afford added cost. As I mentioned, there are shortage of trained prosthetists in most developing countries, and we are using time-consuming technique. And the patella tendon bearing plastic cast technique of sockets is currently the most used in developing countries. These methods are time-consuming to manufacture and require multiple visits from the patient, both pre-fitting as well as post-fitting. There is also a massive shortage of trained orthotist staff, also with the same problem. The education is not providing enough orthotists, and the healthcare system doesn't always prioritize orthosis as an assistive device. So there is a conflict in some countries. To ensure sustainable assistive technology services in every country, the following must be in place. Legislation and regulation that formally recognize and support the profession. Educational institutions should be available that offer ISPO or VHO standard training program. There is also need for a financial model that supports both professional education and access to assistive devices for those in need. Now, if we look at technology, modern prosthetic and orthotics devices are shifting to more direct manufacturing and digital workflows, including 3D scanning and CAD/CAM. This to be able to deliver faster, more repeatable fits and enabling remote service. Advanced material like carbon fiber, reinforced thermoplastic, cut weight and tune stiffness. In the lower limb, microprocessor knees, ankles, and energy storing feet reduce falls and efforts. Post-operative care, rigid dressing, compression silicone liner, and direct socket method shorten time to first prosthetic fitting. Emerging additions include osseointegration for socket intolerance user, meaning patient with very short limbs or similar problem. Embedded sensor for fit and usage analytics on the person who are using the devices. And adjustable interface like vacuum and volume control. And now we are getting into the AI-assisted design as well. In orthotics, carbon AFOs and KFOs, stance control system, clinical exoskeletons, and 3D printed pediatric devices are maturing, meaning they are developing for every year, getting more available and closer to every market in the world. In the upper limb, myoelectric system with multi-articulating hands and target muscular reinnervation, or TMR, expands function of the prosthesis as we know. And this is just to mention few. But it's incredible abnormal to use a leg prosthesis. We try to connect a prosthesis to a skeleton through soft tissue, not created to bear the body weight. We suspend it to the skin through vacuum and friction, which the skin is uncomfortable with, trying to engage muscles where the insertion has been cut off. There is nothing else comparable with how we treat the body as the use of a leg prosthesis. The person that you see on the picture there is Andrea Lanfrey. And to be honest, it is somewhat cynical to claim we can fully solve this, whether with a bespoke prosthesis, individual prosthesis, osseointegration, or even limb transplantation. A person who has lost a leg wants their own leg back. And that's something we can't restore. What we can do is help them achieve the highest possible level of activity and quality of life until the next challenge on their path. However, we have achieved more with leg prosthesis today than we ever have believed we could. Like these 4 persons that you see on the picture here, on the left side, Richard Whitehead, who is bilateral knee disarticulated from the UK. He ran 40 marathon on 30 days from the northern part of the UK. Oops, somebody is playing with my presentation. Sorry, what is happening? There's somebody.
Just if you can share it again.
Yes, sorry.
And I will. Okay, thank you.
Let's see. Yes. Okay.
It's okay now.
It's okay. Yeah, I just have to get to the. Art is beautiful with technique. I think we were here. We were talking about this.
Just sorry, can you say again?
Okay, here.
Yeah, so thank you.
You see it, that's good. That was not what I wanted, sorry. Interesting. Okay. Yeah, let's see. Oh, do you see it now? Do you see the presentation?
Yes, yeah.
Yes, good. I mentioned these 4 people. Richard Whitehead on the left side. He ran from the northern part of the UK to the southeast part. In 40 days, he did 40 marathon. We have Marcus Rehn, who is a unilateral transtibial amputee. He jumped 8.72 meters, and the world record is 8.95 meters. We have Andrea Landfree, the person that you saw on the previous slides. He is a bilateral, and he lost also 7 fingers. He due to sepsis, he went up to the Mount Everest a couple of years ago. And then we have Roman Maximets. I hope you see the video here. This person was injured during the Crimea fight between Russia and Ukraine when the Russians started their invasion. He got seriously injured, and he is transtibial and transfemoral amputee. He is transradial amputee as well. He lost also the hearing on one side and eye on one side. And this person is one of the leading person in helping those soldiers that have been amputated in Ukraine. Very impressive guy. We have, as I mentioned, many new tools in prosthetic and orthotic, like 3D scanning, CAD/CAM, direct manufacturing, microprocess knees and ankles. The challenge is not the invention. It's using these tools well in everyday practice. To keep up, clinics need to simple, repeatable workflows, staff who are trained to use them rather than brand and habit. Clear language and testing standard, like ISO, helps everyone to compare option in a fair way. The practical way forward is to pilot a new method, measure what changes, train the team, and then scale what works while retiring outdated steps. Innovation only matters when it reliably improves comfort, function, and access for the patient. As an example of how we have been taken into new technology, we are all familiar with a vacuum suspension in prosthetics today and how it has changed the option for patients to use a prosthesis. This is a good example of how we have taken new technology into practice. But how good are we in adapting to that technique? Du Bois Parmelee invented and patented a suction device that eliminated later straps on prosthetic devices. And when did he do it? In 1863. That's where he patented his device. Charles de Sutter made the first aluminium prosthesis for his brother that lost his foot in a flight accident in 1915. But he did it without using any vacuum. It was only straps. Vacuum suspension was rarely used in the USA, UK, France, and Germany after the World War II. By October 1949, only about 500 amputees in the whole of the United States were using vacuum suspension. So new technology takes time to implement and start using it. It's nothing new. Healthcare is very conservative in changing method and offering new technology. While 3D printing holds a great promise, the technology is not yet cost-effective for widespread use in the orthotic industry. It is not new. The first time I got in contact with scanning was in the mid-80s. But people talk about it as it was invented just a year ago. Fewer step fabrications reduces failure. Every step, handoff, check socket, curing, or alignment adds variability and creates new failure modes. Where possible, replace multi-stage workflow with integrated single setup method. For example, direct lamination, like direct socket, print to fit orthosis using 3D scanning, and single cure layups. These are all minimizing the long fabrication method. Standard works. Keep result consistent across staff and site. Measure what happens, step per device, rework rate, remark rate, and time to fit. And redesign the process until fewer steps deliver better outcome. New, faster methods, such as direct socket or Amparo, are becoming available, but cost has been a significant issue in the past. This might hopefully change in the future and be more available throughout the world. I'm quite sure of that. This leads us into availability. History shows that only a small portion of people living with limb loss will gain access to new technique during their lifetime. For example, 3D printed parts can theoretically withstand harsh environment. However, heat, UV radiation, and sand can be particularly brutal on a certain plastic and moving components. Today, technology spans to the full range. Implants to enhance residual limb loading through osseointegration, where the prosthesis is directly anchored to the bone. How many of you will have access to this technology today? How much does it benefit the patient? That is the question, still the question today. There are mind control prostheses as well coming up. And as we mentioned, now we can jump longer than most able body if we are using prostheses. But if we look at prosthetic technology and availability today, on the Y side here, where we have the number of those receiving assistive devices, and on the X line we have different prosthetic technology and availability today. Devices on the picture there are highly advanced digital prosthesis. It costs huge amount of money and is only available for those who are richest in the world. Microprocessor knees are getting more available throughout the world. However, it's a very low rate compared to how many transfemoral amputees are in the world. And the same goes with the socket technology. Carbon fibers, however, have been started to be available for much more people than previously. However, the main prosthetic technology available throughout the world is for transtibial amputee, a PTP prosthesis. And in some countries, you can get it in a nice way like this one, with tested components and durability. But most of the people, if getting anything, will get Red Cross prosthesis like this one, where the durability is an issue. And then most of the people only have access to a homemade prosthesis like this one. I would like to use the rest of my presentation to focus on the work of ISPO International in this matter. The four pillars of ISPO is learn, exchange, support, and innovate. ISPO support for the prosthetic and orthotic education and sets international educational standards. The last standard was revised and published in 2017. It ensures program with appropriate skills and resources. ISPO also accredits training program using external independent assessment based on international standards to promote consistent, high-quality education globally. ISPO hosts also global educators meeting every second year to exchange knowledge, share best practice, and plan for future educational strategy. ISPO support continuous professional development for those who have already certification as a prosthetic orthotist. ISPO Learn platform, which was launched in 2022, gives us a free online learning for ISPO members, offering webinars, case studies, symposia courses, and more. In addition to that is our dictionary that we have also. We have annually webinars, 3 to 4 per year. We have short, and somebody close their microphone. Thank you. We have webinar 3 to 4 times per year, short focus sessions on specific topics. In 2023, topics included physical assessment of children with cerebral palsy, wheelchair provision via individual assessment, sub-ischial socket for transfemoral amputees, and I did one seminar on wound management. In 2025, there will be in Netherlands a course focusing on upper limb prosthesis and treatment. So the key message, the need is growing and urgent. More people are living with limb loss from diabetes, vascular diseases, trauma, and cancer. Demand for P&O service is outpacing capacity. Innovation exists, but access lags. Digital workflows, advanced components, and improved rehabilitation models are affected, yet too few patients consistently receive them. Progress depends on collaboration, technology, and training. Standardized pathway, shared data, and upskilled teams turn innovation into routine care. So act now to shape the future. Thank you.
Thank you, Dr. Anton, for your presentation.
Thank you.
Thank you. I would like to ask you, with this advancement in technology and its rising price, is there any solution for low-income people? How to achieve this technology? Like, I mean technology for material only. I mean technology, material, and education at the same time. Okay. And from your opinion, please.
It's a very good question of how things will progress in the future. When I started in this branch, we didn't have any silicone liner. We didn't have a good suspension. We didn't have any microprocessor knees. We didn't have any directly 3D printed functioning in our clinic. But we can't stop innovation. Innovation will continue. And when there comes innovation, those products that were unattainable in the past will become available because they will be cheaper. I think devices with micro technology will get cheaper. I also think that if we are going to include the whole market, I think the large company has to develop alternative for these patient category. The problem here is mainly that you can't give a cheap prosthesis to people in a low-income country. And the reason behind it is that there is no people on the earth that uses the assisted devices as much as the people from poor countries. They use it from morning to evening in a harsh environment. And they never complained, although I have to go walk for 5 kilometers to get water because they don't have any other option. So we can't serve the people in developing country with poor technology. But I believe that there will be more alternative. We have to be innovative to solve it.
Thank you.
Thank you. Just if any of the attendees have any questions, just he can raise his hand and we can give him the microphone so he can talk.
Go ahead.
I ask if any of the attendees has a question, just he can raise hand. Okay, I have a question. You just mentioned about osseointegration in the presentation. So, I just want to ask about like what is benefits of osseointegration? Especially osseointegration is not common. Like amputees don't use osseointegration. They mainly use normal type of socket fitting. So, how to evaluate the osseointegration?
That is also very good question because in the social media you see a lot of patients with different technology, including osseointegration. But the question here is that good for the specific environment? Is it good for use in a hot, humid countries? Is it good for be used in a very cold countries? Do you have to live close to a hospital that is specified in doing this kind of operation? So there is a lot of things that you have to think about before you think of it as an alternative. The experience is that for active people, as we provide prosthesis today, I would not suggest an osseointegration, because osseointegration is limited by the load you can pull on it. You are not recommended to go and run on osseointegration. So if you want to be a high active, then a modern prosthesis is much better alternative. The other thing is that there's a high rate of infection and risk of loosening of the implant. So we are still very reluctant of recommending this, the osseointegration to any patient. And in a serious hospitals where the surgeons are specialists in this method, they have inclusion and exclusion criteria, which they discuss a lot with the patient before anything is done. But it is complicated, and it's still complicated, and there are still lack of studies that support this method over anything else.
Okay, thank you. I think one of the audience has a question. So one of the audience has a question, as to we allow him to talk. Like if you can talk, Saba.
Yes, thank you so much for this presentation. I would like to ask, as a fresh graduate in prosthetics and orthotics, is there any registration or any procedure that is required to have access to the ISPO dictionary and courses they are offering for the piano professionals? I would like to have an access to them. So is it possible?
First of all, congratulations to become a prosthetist. ISPO has some resources like the dictionary, which is open for every members. But if you are going to get more or added value, you will have to become a member of ISPO. And then you have full access of the webinars and the courses that we offer. Is that the answer to your question? Thank you.
Okay. Okay. I'd like to ask you if you hear me, Anton?
Yes.
Yes. Yes. From your opinion, what about 3D printing? You can use it as socket, like Blue Knee, as a fine art socket from 3D printing. From your opinion?
My opinion is that the 3D printing is not a viable alternative compared what's on the market regarding prosthesis or lower limb prosthesis. But as for orthosis, ankle foot orthosis, I think it will be a standard within some years. More development is needed to see it as an alternative in prosthetic fitting, in my opinion.
Yeah. Thank you.
So thank you, Anton. And I don't see any questions. So if there's okay, I think okay. If there's no, yeah, there's one question, other more question.
Awesome.
Yeah, Abdurrahman.
You have to unmute your microphone.
Abdurrahman, do you want to talk? So I don't think, yeah. So if like, so okay, Hazim, you want to talk? Hazim, you want to talk? You can unmute yourself. Okay. If there's no more questions, so thank you, Anton. And for attendees, we will share now a QR code. If you just scan this QR code and complete this form for your attendance for this webinar, so we can send you attendance certificate. So we share now a QR code.
Mm-hmm.
Thank you, Anton, and I hope see you again, not in another presentation, but
So 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 they can scan this QR code.
Mm.
If
Okay, yeah, good question. That's very good.
Okay.
If there is any question, they can send it to you, Ayman, and we can take it from there.
exactly, yes.
Oh, okay.
And I hope see you again in another presentation.
Same.
And in your second home in Egypt is available, like Iceland now.
Thank you. Thank you. Thank you for this opportunity.
Thank you for your time.
Have a nice
Thank you
evening.
for your time.
Thank you.
Thank you. See
Bye-bye.
you. See you.
Thank you. See you. Bye.